Hello, my name is Kate Chesterman. I'm a salaried GP in South Norfolk, and I also co-host the GPnotebook study groups. Welcome to the GPnotebook podcast, where we discuss bite-sized topics aimed at all those working in primary care. You can find us on all major podcast platforms, including Spotify and Apple and Google podcasts. Please follow us to receive notifications about new episodes, and if you like what you hear, please consider leaving a review to help other listeners find us. You can also follow us on Twitter at GPnotebook for more information about new podcast episodes and study groups. Finally, you can visit GPnotebook.com for podcast episode show notes and to find out more about upcoming study group meetings. Today I'm going to be discussing Morton's neuroma, which is also sometimes known as Morton's metatarsalgia or interdigital neuroma. So let's start by thinking about how this might present to us in primary care by considering a case study. Jane is a 47-year-old lady who made an appointment to see you because she has been getting intermittent pain in her right foot. She describes a shooting pain in the ball of her foot and a tingling sensation that spreads from her forefoot into her third and fourth toes. Jane has also noticed that at times she feels like she's walking on a marble, and that this is particularly noticeable when she's barefoot. She comes to see you today wearing trainers, as she has found that these are more comfortable, but she does admit that she prefers wearing shoes with a heel. When you examine Jane's foot, you can't see any lumps or skin changes, but there is a tenderness in the third web space between the third and fourth metatarsals. So, Jane is describing quite a classic presentation of a Morton's neuroma. Now, calling it a neuroma is actually a misnomer, as there isn't a tumour present. But what we do find is a thickening of the tissue surrounding the digital nerve leading to the toes. It's thought that this thickening results from repeated compression, irritation, or trauma. The nerve is in a tight space between the metatarsal heads and underneath the intermetatarsal ligaments. If the nerve becomes trapped, we find resulting inflammation that leads to the formation of scar tissue. The space between the metatarsals is narrower between the second and third and fourth toes, and therefore nerve compression is commonest in these areas. The condition will be exacerbated by anything that increases compression in this area, and so the wearing of tight-fitting shoes with a narrow toe box will commonly exacerbate the symptoms. Women are affected 8 to 10 times more than men, and patients typically are affected between the ages of 30 and 60. The pain is often intermittent, and some patients can have long intervals between episodes of pain. But other patients can unfortunately develop chronic and persistent pain. Patients will usually describe a burning or sharp pain in the ball of the foot that can radiate into the toes and is sometimes associated with numbness or paresthesia. These symptoms are particularly common when undertaking weight-bearing exercise, and they're usually relieved by rest and the removal of shoes. Night pain is less common. The feeling of walking on a pebble or marble is also commonly described, and this sensation is usually felt between the base of the third or fourth toes, or less commonly between the second and third toes. Sprinters may complain of pain when pushing off from the start block, and high heels replicate this foot position and will also frequently cause pain. The diagnosis is usually a clinical one, based on the history and examination findings. There is usually little to see or feel in terms of a lump, but a patient with Morton's neuroma may well have tenderness in the affected interdigital space. Various clinical tests have been suggested to try to aid the diagnosis, and probably the most commonly used is Mulder's click test, where the clinician uses one hand to squeeze the metatarsal heads together and pushes the affected web space with the other hand to see if a palpable click can be elicited. It's worth being aware, and certainly warning your patients, that this is likely to be painful, and we can get false positives in normal feet. The examination of the foot is also important to look for other causes or exacerbating factors of forefoot pain, such as flat arches, hallux valgus, or signs of inflammation. There are very few investigations that we might want to consider in primary care, and these are mainly used to rule out possible differentials. A full blood count, inflammatory markers, and urate may be useful to help rule out gout, other inflammatory arthropathies, or infection. And X-rays could also be considered to rule out other pathologies such as a stress fracture. But caution is needed as the sensitivity of X-ray for detecting stress fractures is low, especially in the early phase of the injury. An ultrasound scan or MRI can also be considered if the diagnosis is in doubt, to help confirm the presence of Morton's neuroma and to rule out other differentials. So with Jane's classic symptoms and a finding of tenderness in her third web space, we felt confident of the diagnosis. So what can we advise her to try to relieve the symptoms? Well, a trial of simple self-care measures should be the first line of treatment, and we can advise Jane to rest, use ice, and take simple analgesia such as paracetamol and anti-inflammatories, as long as there are no contraindications. Patients should also be advised to wear wide, comfortable shoes with a low heel and soft sole. Metatarsal pads and insoles can be used to redistribute weight and minimize plantar pressure. If patients are overweight, then encouraging weight loss will also be beneficial. Encouragingly, around 50% of patients will get some degree of relief with these conservative methods. If symptoms don't improve with 3 months of these suggestions, then a referral to orthotics would be appropriate. And if pain is continuing despite orthotic input, then we should consider a referral to a foot surgeon. Corticosteroid injections, usually done with ultrasound guidance, can give successful relief in around 50% of patients. Radiofrequency ablation of the nerve sees an improvement in around 70 to 80%, and surgical intervention in the form of a neurectomy or decompression will give relief to 80 to 95% of sufferers. Finally, do note that up to 20% of patients can experience a recurrence of their symptoms even after surgical treatment, and it's worth being aware of this if a patient returns to see you with a relapse of their former symptoms. Patients must be aware that the advice regarding wearing wide, comfortable shoes with a low heel and soft sole should be adhered to even after a corticosteroid injection or surgery to reduce the risk of recurrence. So thank you all for listening. I hope you found this podcast helpful. Please do have a look at the show notes that accompany this episode at GPnotebook.com, and would be very grateful if you would consider following the podcast and leaving us a review on your favourite podcast platform. Feel free to get in touch via social media at GPnotebook or email support@gpnotebook.com if you have any questions, comments, or ideas for future episodes. You should also visit us at GPnotebook.com to register for our virtual GP Notebook study groups and download free shortcuts which are designed to help make your lives a little easier and ultimately help improve the lives of our patients in primary care.